Thank you very much again for the opportunity to speak. Why consider rectal sparing approaches to rectal cancer when we have a curative, perfect procedure, which is the low anterior resection or the abdominal perineal resection that addresses the lymph node deposits and is the standard of care? Well, as it was mentioned earlier by another speaker, surgery is a little bit like art, and we're probably sculptors. And if you think of Galatea, that the sculptor fell in love with, I don't know that we as surgeons would fall in love with the results of our surgery when we see patients after low anterior resection. Many of them suffer from fecal incontinence. The ones that are not radiated have the rate of fecal incontinence of 25%, and those who get radiation the rate goes up to 60%. Patients also complain of urinary incontinence, of multiple bowel movements, of frequency, of urgency. It is not a perfect operation, even though it may be curative. Not surprisingly, therefore, many patients come to us and say, is there anything else that you can do? And the rates of and they become even more despondent if we tell them that they need to lose their sphincter as a part of this curative resection, because even in the United States, the rates of sphincter surgery, the sphincter sparing surgery, are about 50%. Many patients have to give up their continence completely. And so, because of that, the trend for local resection in the United States is rising, and it's rising even though it's rising for one reason, because the complications are low when one performs a local resection, including the other complications, which are the anastomotic leaks. But more importantly, the trends are rising despite the fact that the data suggests that the survival after surgery, when you have a local resection, is lower than the survival after a low anterior resection or an abdominal perineal resection. Why? Because the patients want to spare their rectums. And so we as surgeons need to listen to them, and we need to figure out who is an appropriate candidate for this approach to try and not decrease the survival of our patients, but also balance their wishes. So when people talk about local approaches, we need to understand that not all local approaches are the same. And when these authors said, listen, the survival of everybody who has a local resection is worse than a low anterior resection, in their data they included people who had fulguration, cryosurgery, excisional biopsies, and something called local excision without a pathology specimen. I'm not sure what that is. What we as surgeons should be meaning by local excisions are techniques that allow for a full thickness removal of the specimen with an R0 resection, in other words, no tumor left behind, and a local excision in a patient that had appropriate preoperative staging to exclude as much as possible presence of concomitant lymph node deposits. And therefore, that would either be a standard transanal excision or a transanal endoscopic microsurgery for higher tumors. How do we stage patients? You've heard this in detail, and you've also heard that we are not able to completely exclude lymph nodes with any technique, whether you do ultrasound or whether you do MRIs. And therefore, what I would say is that you need to know how good your radiologists are at your institution, because MRIs are also operator dependent, not just ultrasound. When we looked at our hospital, we were told this particular group of T1 and T2 patients don't have positive lymph nodes. We took them to the OR and did a low anterior resection. What we found is that 20% of these patients actually did have positive lymph nodes on the final pathology. 11% in the T1 group, and 27.7% in the T2 group. And that gives me a big, pit in the stomach every time I'm considering doing a local excision on somebody with a T1 cancer. T2 is even worse, poorly differentiated, even worse, lymphatic vascular invasions, all of these high-risk factors make me worry even more about putting a patient through a local excision. And so there is this balance. On one hand, there is the high complications, the risk of colostomy, the risk of low anterior syndrome, in the patients that may get an unnecessary radical surgery, and that would be 9 out of 10 patients with T1 cancer versus the 1 out of 10 patients who has risk of local recurrence and a high recurrence rate. It's a very tough balance. And here's another thing. Local excisions appear to have recurrence rates that are higher than you would guess by looking at the rates of lymph nodes only. This is the data from University of Minnesota, and what they showed is that for T1s, their rate of local recurrence was actually 28%. That's higher than the lymph nodes that you would expect, which is 10%. And for T2, they had a 47% local recurrence rate, as opposed to the 6% recurrence rate in the low anterior resection and APR patients. And this data was the rates were not as high as at other institutions, but the table here includes a lot of people that also had preoperative or postoperative radiation. One thing is clear, though, is that the overall survival was lower, both at the Minnesota and in the other centers. So why is that? Why is it that the local excision rates are higher than the lymph nodes? And I think it has to do with the fact that we're probably seeding tumor when we're doing our local excisions. You're banging on the anus, you're pulling, it's bloody, it's hard to see. And also, obviously, you can do local excisions on a lot of tumors that are higher up. And here comes transanal endoscopic microsurgery. And I'm sure a majority of you are familiar with this technique because it's been around for over 20 years. In fact, it preceded laparoscopy. The first TEM case was done before the first laparoscopic cholecystectomy. And in this case, the proctoscope was inserted into the rectum, and because you have magnification, you can see better where the tumor is. You can mark the borders of the tumors with much more care. And that is also, okay, what happened? It's possible because while you're doing that, you have the insufflation, the binocular vision. It allows you to do a full thickness excision, for which you can do intraluminal suturing, and it allows you to go higher, up to 18 centimeters. There is a debate about whether that leads to less anal sphincter trauma, so we're going to leave that point, for another discussion. But now there's cheaper technology that allows you to do TEM without the fancy equipment that Dr. Buse invented originally. You can use the TAMIS device, which means that any of you can go and do TEM without buying extra equipment. Why learn? Well, the reason to learn is because it appears that TEM is actually superior in terms of local recurrence rates to a standard local excision, and that is because you have the magnification and the ability to clearly delineate normal from abnormal. In addition to that, and this is the data from Minnesota. Remember the paper where I showed you that they had a 27% local recurrence rate for T2? Well, this is their data for T1s and T2 with TEM. And you can see that now the local recurrence rate is the recurrence rate you would expect based on the positive lymph nodes that are left behind, as opposed to other things that we somehow are doing when we're doing standard local excisions. There's actually one randomized controlled study between TEM and anterior resection in a very, very carefully selected group of patients. And in this study, they found no significance in terms of the recurrence rates between the two groups. But again, this was T1 patients with very good histological features. And TEM is cheaper, interestingly enough, just because you don't have to recuperate the patient as long. But again, the recurrence rate is a little bit higher than an LAR, predictably, and it's a lot higher if you're doing this on high-risk patients, so don't do that. And again, this is just another paper that proves the same thing. It comes down to proper selection. If you do TEMs on T3 patients, of course they will recur. T2 patients, yes, they will recur. But if you do T1 patients, this is all comers, and then you stratify and you do it only on people with good histological features, the recurrence rate is acceptable, and that is a reasonable rectal sparing approach in this group of patients. Now, how about T2s or people with high risk features? There's a lot of data that starts from 1999 that shows that if you take these patients and offer them neoadjuvant or adjuvant chemotherapy and radiation, the recurrence rates go down. This one shows, high-risk patients, 37% recurrence rate versus 85. T2 patients, 33% versus 85. Which is why the American ACUSAC trial was formed by Dr. Garcia Aguilar, and it actually completed accrual. It was a phase 2 clinical trial where they had surgeons from all the United States recruit UT2 patients with N0 disease based on either ultrasound or MRI or both. These patients were then offered preoperative chemotherapy and radiation, and the idea is to try and figure out whether that can expand the opportunity to do local excisions on this cohort of patients. The data from this trial is not yet available, even though the accrual is completed. There's only preliminary short-term data, which shows that 79 of these 90 patients that were originally recruited finished their preoperative radiotherapy. Of these, 77 eventually underwent local excision, and you can see that 44% had a complete pathological response, so that's a nice, and another 64 were downstaged. But again, look at that, 5% had YPT3 tumors instead of the T2s that the surgeons thought that they were treated, and there was actually one positive lymph node removed during these local excisions. So it will be interesting to see what the data of this trial shows. And another interesting thing about this trial is that they had a lot of dehiscences, and the rectal pain in these patients after radiation followed by local excision was high. Things to keep in mind as we're thinking about what to do with the T2 patients and local excisions. And how about rectal sparing for even further advanced tumors? And this is even more controversial than everything I've been saying so far. The idea is, could you select the patients that have a complete pathological response and observe them instead of operating on them? This idea was pioneered by Dr. Habergama, and I'm told that when she presented her data in 1998 at the American Society of Colorectal Surgeons, after she said, listen, I had these 30 patients that I observed, 8 out of them eventually recurred while I was observing them, so they needed the low anterior resection, but I caught them on time. The other 22 were spared surgery, and the overall survival was 93%. The disease-free survival was 85%, and this survival was the same as the rate of survival in the patients who had surgery from the start. When she presented this data, she was actually booed off the stage. I'm told that, when she said, are there any questions, the moderator said, in this session, we will only ask questions of serious abstracts. And then she had to leave the stage. But she must be an iron woman because she kept on writing on this topic and published numerous manuscripts and has a series that now runs from 1991 to 2009. And if anything, she's showing that as the chemoradiation improves and as the technique of follow-up and frankly, experience of who to select for this, their rates of local regional failure are going down. And if that first series, it was 27%, and the paper that she published in 2011, the rate is 4.6% failure rate. And this result is now being replicated at other institutions. This is a paper that was published in Journal of Clinical Oncology this year. And it's from Netherlands, where they took 192 patients with advanced rectal cancer. And out of this 192, they only selected 21 patients for observation, okay? They were deemed to have a complete clinical response. 10 of these would have needed APR if they would have gone to surgery. And they compared them to the 20 patients who ultimately turned out to have a complete pathological response at TME, who for some reason were not observed, or maybe they had some thickening of the MRI and on the endoscopy, and they thought not to have had a complete pathological response. And what they said, understandably, short-term, the bowel function with observation was much better than the bowel function in the patients that had TMEs. And long-term, only 1 out of the 21 patients that were observed had a recurrence. That patient underwent a low anterior resection, had a complete resection of a PT1N0 tumor, and overall, this group had a 2-year disease-free survival of 89% and an overall survival of 100%, as compared to the group that was operated, where actually 1 patient died from a surgical complication at the colostomy closure, and another one developed metastatic disease, which, it could occur even when you have a perfect TME. But the disease-free survival and overall survival in this cohort was about the same, and again, it's 20 patients, so it's hard to comment. Again, though, be careful. That's 2 groups. There are many other groups, and the other groups report outcomes that are all over the map. And in some groups, the recurrence rate is as high as 83%. So what's that mean? Well, what I think it means is that it all hinges on an extremely careful selection of who should be observed. And the Haber-Gamma group wrote a whole bunch of papers trying to explain to the rest of us how they do it. And it appears to be a very careful endoscopic evaluation where they look at no residual ulceration, irregularity, nodules. They say maybe a little bit of whitening is allowed and a little bit of telangiectasia when you do the endoscopy. They do MRIs, make sure there's no wall thickening and no rectal thickening, obviously no residual lymph nodes that they can see. And interestingly, I would think that you would want to biopsy, but they think biopsy is not useful because it only takes 1 little bite. If they say if you're going to do a biopsy, excise the whole scar and do a TME. But just like in the Garcia-Aguilar series, what they say, the recovery from that TME after a person was, local excision, the recovery from that local excision to prove absence of cancer is horrendous. The complication rates are high. The dehiscence of that wound is high. So actually the Haber-Gamma group argues against biopsies. They say, look and see. You see anything abnormal, take them to the OR and do the right low anterior resection or an APR. And if it is normal, then stick to it and keep observing clinically rather than taking nibbles out of the tissue. And this is from the Moss paper that I told you about earlier, where they show somebody with telangiectasia after chemotherapy and radiation that they observed, as opposed to this person that had a little bit of a nubbin of tissue that they were not happy with that they took to the operating room. And again, it also hinges on very careful follow-up. If you're going to observe, you better look at these people every 3 months at least. In the Moss paper, they also did endoscopies. The Moss group actually did biopsies as opposed to the Haber-Gamma group. And they also doing MRIs, occasionally PET scans. So there is a lot of investment of time in the patient that doesn't get surgery. So to conclude, no question, a low anterior resection and APR is a curative operation, but it comes at a high price. And our patients, not surprisingly, keep coming to us asking about sphincter sparing and rectal sparing. And I think that for early T1s with histologically favorable features, a local excision makes sense. T2s, up in the air. Right now, T2s, we recommend a low anterior resection, right? But it will be interesting to see what the ACUSAC trial shows, and perhaps the indications for local resections will be pushed further if we offer patients neoadjuvant treatment. And then finally, the wait-and-see approach. I think we need more data on that. I think that this is still not the standard of care. It is very intriguing to read the papers that are out there on this topic. And I say, if you're going to consider that, you need to tell your patients that that's not the standard of care. You have to choose those patients extremely carefully, and you have to be prepared to offer paranoid surveillance from there on so that you can catch them early should they have recurrence, so that you can still offer them long-term survival. Thank you.